try to convert over from plain Sinemet to Rytary, you got to be careful that you don't undertreat. But I've had some patients that are getting 5 or 6 hours and are able to go down from 6 or 7 doses of Sinemet a day down to 3 capsules of Rytary. So that is a potential benefit, and theoretically, by having what we call that continuous dopamine stimulation, maybe we can avoid that up and down of having to take Sinemet 7 or 8 times a day. So Rytary's on the market, FDA January 15, and it's being used. And it's primarily for the patient who is up and down and is taking drugs 6 or 7 times a day. The next continuous drug is the Duopa pump. It's a liquid formulation of Sinemet. You have to have a tube placed through the abdominal wall into the jejunum. You wear a belt, a pump like an insulin pump, and from 7 o'clock in the morning till 10 o'clock at night, the amount of Sinemet that you would normally take in a day is pumped in at a continuous rate. So if you take 12 Sinemet tablets a day and you have the pump turned on for 12 hours, the pump will pump in 1 Sinemet tablet an hour. I must say I have no one in my practice currently that has that, and people are a bit intimidated by the idea that they have to have a jejunal pump, which means they have to essentially have a tube through the abdominal wall into the jejunum. So people are somewhat intimidated by that. I have not seen anyone yet who's willing to take that step. The Nupro patch, that's an agonist like Mirapex or Requip. You wear that for 24 hours. Theoretically, it's a continuous infusion of Nupro. Unfortunately, Nupro is not that strong a drug, and you're somewhat limited in the dose, but that with Rytary, the Duopa pump, Nupro is another attempt to have continuous dopamine stimulation. There's an apomorphine pump, which is basically another agonist that's available in Europe, and it's going to come over here. I think that I talked to a neurologist over in the East Coast that's had some issues with it because it's apomorphine, and people trying to bring that over from Europe over here. As soon as anybody at the border sees morphine, there's this big concern that it's, so there's been some issues about getting it over here and getting it functional. I have not seen anybody on the apomorphine pump. It's big in Europe. And number 5, of course, would be the DBS. That continues to be a growing approach. There's papers coming out now suggesting that best medical therapy with drugs, Sinemet, Requip, whatever, best medical therapy still, it's difficult to demonstrate as good a benefit as you can get from DBS. And I think there's certainly a trend towards the idea that DBS is a last resort for someone who's tried everything. Certainly there's a trend coming back where clearly DBS is starting to be advocated for people earlier in the disease. And there's a trial out right now called eSTIM, Early STIM, where they're enrolling patients for DBS that have had Parkinson's disease for 5 years. So there's clearly an excitement about DBS. We're going to be doing DBS for weight loss and depression, and we're doing DBS for seizures, Tourette's syndrome. There's a number of neurological problems that are going to be treated with DBS. It's sort of the wave of the future. Well, at least it's not mine. Hate to have to run off the stage. So I'm not going to spend too much time about the drugs that we have available to us now. You're all familiar with that. if I'm on a ship, and I often tell patients if I'm on a ship and every drug available for Parkinson's disease is in the hold, and I can only save one crate, it's going to be carbidopa, levodopa, Sinemet, still the #1 drug to treat Parkinson's. If you have Parkinson's disease and you live long enough, you are at some point going to be on carbidopa, levodopa, so-called Sinemet. The other drugs are second tier, Mirapex, pramipexole, Requip, ropinirole. Those are all second tier. I tend to use those more in younger patients. If I've got a 60-year-old with Parkinson's, I may try an agonist first, Requip or Mirapex. An 85-year-old is going to go right to Sinemet. The other drugs, I don't use a lot of Stalevo, which contains Comtan, but theoretically Stalevo lasts a little bit longer. Sinemet controlled release lasts a little bit longer, but I think those drugs are going to sort of be dampened down a little bit because of Rytari, which is really the ultimate long-acting form. Amantadine is another drug. I use that mainly for dyskinesia. Anticholinergic drugs have a role, but used very little now. Artane, those kind of drugs. So I would say that the main drugs for Parkinson's would be carbidopa, levodopa, Sinemet, and the second tier would be Requip, Mirapex, and the Nupro patch. But I think that Rytari is going to move into that space. There's a lot of people that are actually advocating starting Rytari in patients de novo, rather than waiting until they develop all sorts of side effects because of that continuous dopamine stimulation concept. And if anybody has any questions about the drugs, I'd be happy to talk about them, but I think that if the ship's going down and I can only save one crate, it's going to be carbidopa, levodopa, Sinemet, taking into consideration that it's not an easy drug to take, it's not an easy drug to manipulate as a physician because it has such a brief length of time that it's active, and if you can get 3 or 4 hours from it, you're happy. And the patient comes in initially with Parkinson's, and you can usually get by with 3 times a day dose. Not too long after, the patient comes in saying the first dose isn't lasting till the second dose. So there's this gradual shrinking of the time between the doses until people are taking pills 8 times a day, 1 every 2 hours sort of thing. So that's the negative about Sinemet, and that drove the research people to try to come up with these drugs that prolong the effectiveness of L-Dopa. But that's still the #1 drug. A couple of other things I wanted to point on, which often are driven by the patients, and going back to that idea that we need drugs that are going to have an impact on alpha-synuclein. There was actually a published report over the last year referring to a drug called Tasigna, which everybody's interested in, nolitinib, and it's a cancer drug used for leukemia. And there was things in the paper about it. There were 12 patients that were up in Georgetown. There was a Dr. Musa who had that study, and it seemed to show evidence that it was able to eliminate alpha-synuclein from the brain. The way they proved that is that the patients got better. They got better cognitively, and they got better motor skills, but they were able to show that people with Parkinson's disease, because the alpha-synuclein is deposited in the brain, that the level of alpha-synuclein in the spinal fluid is low. So when they gave this drug to people to theoretically eliminate alpha-synuclein from the brain, the levels of alpha-synuclein rose in the spinal fluid. So they concluded that obviously this drug was reducing alpha-synuclein. So there's been a lot of interest in Tasigna. It's also called nolitinib, and it's a cancer drug, and there was one 12-patient study in Georgetown, but a lot of patients called and was interested in how can I participate in the study. And it's always an issue in these studies because where do you go from here? If you want to be involved in a study, you'd probably have to go up to Georgetown, and the phones were ringing by people that were interested in this drug, and it becomes very problematic because how do you get involved in a study of this drug? You have a 50% chance of being in the placebo group. Are you going to move up to Georgetown and rent an apartment and live? So I think that it's an interesting drug that deserves more study, but the average Parkinson's patient is going to have a very difficult time participating in that study. And a lot of people were inquiring about that, and it's of interest. And I think it's of interest because there's some evidence to suggest that it may actually do what I was saying earlier. It may actually reduce alpha-synuclein in the brain as measured by spinal fluid alpha-synuclein, and the patient got better. I mean, I haven't seen the films myself, but there's a neurologist over who specializes in Parkinson's disease on the East Coast that was actual video of the patients, and there was evidence that these patients got better over time receiving this chemotherapeutic agent. It's an oral agent. You just take it daily, and you don't take it anywhere near the dose that you take to treat leukemia. But there's a drug that there's some initial excitement about because of its role in alpha-synuclein, but it's really not available to the average Parkinson's patient right now unless you, I'm sure that Georgetown was swamped by people wanting to participate. So it would be very difficult for the average Parkinson's patient to participate in that study. Now, what I'll do now is maybe I've got a couple of beefs I want to, or a couple of comments I want to make. Stem cells. I have to say that this has become a very controversial area, and there are actually physicians in Naples, and I don't know about Fort Myers, et cetera, but there's physicians in Naples that are using stem cells as treatments. And you can go over to Miami and have an adipose stem cell treatment for Parkinson's disease, and I think for other neurodegenerative diseases. Unfortunately, none of these treatments is there any data to support their use. So if you go on the computer and you research and you go into the website of the International Stem Cell Society, there's really no, you go on some of these stem cell websites and they have groundbreaking and they have videos and they have, state-of-the-art treatment, but there's really no studies, placebo studies that show that stem cells are really of any benefit at this point. So the idea that you're going to go over to Miami and spend 10 to 15 grand on a stem cell treatment for Parkinson's, or I would even argue that having a stem cell treatment during an orthopedic procedure, I'm not saying don't do it, I'm just saying you're basically participating in a research study. There's no good data, there's no good evidence to support that. And of course, these treatments are all cash. So the insurance companies are not going to pay for these treatments. These are cash-driven treatments. So I'm just saying that, hey, you do what as I say to most patients, do what you want to do. But these stem cell treatments, there is no good data to support their treatment for neurological disease, for orthopedic disease. I have people coming in. I had a patient in last week. He's going to have both his knees replaced, and at the same time, he's going to have stem cells implanted into the knee of each knee at $2,500 a pop. So it's going to be $5,000. And it's been sort of hinted to him by the person who's doing it that maybe it'll hasten recovery and maybe it'll reduce infection. But there's no data to support that. But people can't write those checks fast enough. And I always joke that there's a patient in an office 2 doors away from me that's writing a check for $5,000 while I'm getting my the patient tearing me a new one over a $10 copay. So, I think, so I always find that fascinating. So I would say beware. I've had patients going over to Miami, 10 to 15 grand. It involves a small incision is made in the abdomen. They harvest some adipose tissue, spin it down, and it's injected, and I think the whole thing lasts about less than an hour, and that's 15, I think, 12 to 15. So, and I don't know how many of those they're doing in a day. But, I mean, it's clearly, from my perspective, economically driven. So I would say be wary of stem cells. Now, there is some stem cell research being done. I mean, there are some articles about research into stem cells and the potential that they, down the road, we may actually be using them in a therapeutic way, but I think there's no good data to support the current use. I have the same attitude about supplements. So I'm in the office and somebody comes in with a shopping cart. I think, gee, can't that guy, I think to myself, gee, wouldn't it be easier to get a walker or something like that? And then I take a closer look, the shopping cart is filled to the brim with alpha, beta, gamma, wadaba, zabadaba, dubadaba, labadaba, zabadaba. I can't even pronounce half the supplements. And I think there's no data to support any of this stuff. And they got newsletters, and there's a doctor on there saying, gee, secret cure for Parkinson's, and you go through it and it's like blueberries or something, and so I would be very wary of these supplements. People are constantly bringing in all these supplements. They get them off the internet. Uncle Bob, who's the retired postal worker, was on the internet and emailed them that, they got it, it's pussy willows or something. But I mean, it seems crazy, but it's a daily phenomenon for me. I've got people going into chiropractors' offices, and they're getting, they're getting attached to machines that vibrate, and I've got people going and sitting in a chair between two huge magnets, and I've had people, of course, do the hyperbaric oxygen and the IV glutathione, and after a while, I got a number of these patients that have spent a considerable amount of money on these, whether it's magnets or this or that, and they come to me, and I've got my own, I guess, stable of patients, and then occasionally I get patients that have had these intense vitamin, and they're, I don't know how they have the time to take all this stuff. But if you read in the Naples Daily News, there's 3 of them every day. And there's a guy with glasses, he's got the research glasses on, he's wearing a white coat, and there's usually a Bunsen burner going, and this is, it's some new drug supplement that's been developed that's going to make you, in a month you're going to be on Jeopardy or something, they're going to say. But I finally realized after a while that when those patients came to me that had been seeing alternative doctors, they didn't look any different than my patients. So I thought, well, hey, if all that hyperbaric oxygen and alpha, beta, whatever, and all this IV stuff and all that, how come those patients didn't come in looking, great, and they looked a lot better than my patients? And I finally said, hey, after a while I couldn't really tell who had, in my practice, I forgot who'd been on the supplements, who'd not. And I went back to the old, when I was in my training up at Cleveland Clinic, the joke used to be that the reason they call it holistic medicine is that it leaves a big hole in your wallet. So I would be very wary of the supplements, I'd be very wary of, but maybe I'm too mainstream. I'd be very wary of laser surgery, or any of these things, supplements, all those things you read about in the newspaper where you can't pronounce them, alpha, beta, and some people take an incredible amount of them, and some of them I can't even pronounce, and neither of us really know what they do. So there's no supplement that's been demonstrated so far to be beneficial in Parkinson's. So I think that's very important. Of interest, there's a new drug coming out on the market you may have heard of. It's called pimavanserin, and it's going to be quite beneficial because it's going to be helpful for behavior problems in Parkinson's, for hallucinations, psychoses. So that drug will be coming out. The FDA just passed that within the last week or two. So that's a drug that you'll be hearing about. And that's kind of sort of covers what I wanted to cover today. I think you soon learn in this business that you get people for a certain chunk of time and then you kind of lose them. But I think if I would say that there's some excitement out there, alpha-synuclein drug, Tasigna has shown us that maybe clearing alpha-synuclein from the brain is going to be some benefit. And I think the focus now is going to be on treatments to reduce or eliminate the deposition of alpha-synuclein in the brain. The same way you're going to be reading about all these treatments that are trying to get rid of tau and primarily amyloid from the brain and say Alzheimer's disease. So hopefully you learned something today. And that's all I have to say.